Welcome to the latest installment of the AST Journal Club series. Today's session features the American Journal of Transplantation article, Sexual Bother and Sexual Activity Before and After Kidney Transplantation. This session is sponsored by the AST Women's Health and Kidney Pancreas Communities of Practice. In a moment, I will turn the session over to our moderators, Dr. Vasanth from Emory University and Dr. Silvi Shah from the University of Cincinnati. But before we begin the main presentation, we do have a quick viewership poll for the audience. There is currently a viewership polling question displayed for the audience. Please take a moment to answer this question while we finish the remaining announcements. We encourage you to use the chat window during the Journal Club to share your thoughts and comments. However, if you have a question to submit to our panelists, we recommend using the Q&A button in the Zoom webinar panel. Questions submitted via the chat window may be missed during the presentation. This Journal Club is being recorded, and the archive will be available on the MyAST website and the AST YouTube channel in 2 to 3 business days. Finally, when you log off at the conclusion of today's Journal Club, you will see a link to a short evaluation survey to complete. Please fill out this survey to help us keep our content current and engaging. I will now turn the session over to our moderators, Dr. Vasanth and Shah, to begin our presentation.
Thank you, everybody, for attending this journal club. Today's journal club is on sexual bother and sexual activity before and after kidney transplant. We are really excited to have Dr. McAdams-DeMarco with us. She's an associate professor and associate vice chair for research at NYU School of Medicine. And we are very excited to have Dr. Long, who is a surgical resident and a PhD candidate with Dr. McAdams-DeMarco. I'm going to hand over this session to Silvi to introduce Dr. McAdams-DeMarco.
Thanks, Payas. So we are very excited to welcome Dr. Mara McAdams-DeMarco. She is an epidemiologist who serves as an associate professor and the associate vice chair for research at the NYU Grossman School of Medicine. Her NIH-funded research focuses on the intersection of aging and kidney disease. She has been the principal investigator on the largest and oldest prospective cohort study of physical and cognitive aging in kidney transplantation. And she was a 2024 recipient of the American Society of Transplantation Clinical Investigator Achievement Award and American Society of Nephrology Mid-Career Distinguished Researcher Award. She is the co-director of the International Kidney Disease Aging Research Collaborative. And Payas will now be introducing Dr. Long.
Dr. Jane Long is a general surgery resident at Mayo Clinic, Rochester. She's also a PhD candidate in epidemiology at NYU. She conducts research as a part of the C-STARS program, a Center for Surgical and Transplant Applied Research at NYU, under mentorship of Dr. McAdams-DeMarco and Dr. Doris Segal. Her research focuses on aging and dementia in transplantation. We are very excited to have you here, Jane.
Thank you. I think we'll get started with the Journal Club.
Yes.
Wonderful. Jane and I would like to first thank the American Society of Transplantation for the honor of being invited to give a talk on our paper that was recently published in the American Journal of Transplantation. We'd like to recognize the co-authors for their contributions to the work. And we're excited to share a project that came together in a way that we thought was quite interesting and informative for patient care. Jane, next slide, please. We'd like to acknowledge the role of the NIH in funding this research. Thank you. Next slide. Neither of the two hosts have a relevant conflict of interest to disclose.
For a little bit of background information, sexual dysfunction is common in end-stage kidney disease due to hormonal changes, dialysis, psychologic burden of chronic disease, and comorbidities. Over 80% of patients report their sex lives are impacted by kidney disease. Sexual bother, the negative impact of dysfunction affects quality of life and may improve after transplantation. But little is known about sexual bother and activity changes, especially in women. Sexual health are undervalued components of health, but are important for quality of life in patients with end-stage kidney disease. 40% of patients on dialysis perceive sexual activity as an important part of life, yet 60% of patients reported no sexual activity before transplantation. Sexual dysfunction is also a concern among transplant recipients who may face changes due to post-transplant physical and emotional effects. And post-transplant improvements in sexual function and activity may positively impact patients' lives and reduce sexual bother. Previous research have centered on erectile function, but have not focused on broader changes in sexual bother and activity, and as mentioned before, less focused on women's sexual health. So our study objectives were to characterize the degree to which kidney disease impacts sexual bother, to understand the association between patient characteristics and sexual bother, and to understand the trajectories of sexual bother and sexual activity before and after transplantation.
Thank you, Jane. I'll take over and give some brief introduction to the methods for today's study. Next slide. So our cohort study originated in 2009 with our current study looking at the questions in the kidney disease quality of life, which we'll talk about in just a minute, starting in 2014. This is a cohort study that Dr. Dori Segev initially started while we were at Johns Hopkins and has expanded to become a two-center prospective cohort study. We like to think of our study design as being two separate cohorts. The first is a group of candidates who were evaluated at these two centers, both Johns Hopkins and NYU. For the candidate cohort, there were over 2,422 participants that were enrolled at the time of kidney transplant evaluation. This means that we're meeting participants as they're coming in for their clinical care, and we are enrolling them into our study and performing all study activities at that time. The second group is our recipient cohort, of whom there are 490 participants who are enrolled at admission for kidney transplantation. Through the hard work of the research associates who work in our lab, we see participants as they're being admitted, regardless of the day, the time of day. We meet recipients there at admission to be able to perform study-related activities as well. This work includes the data that was collected up through the end of 2023. Thank you. Next slide. The overall study design for the cohort allows for both collection of self-reported data as well as measuring different items. First, we ask participants to describe their characteristics. Through self-report, we get such characteristics as age, sex, race, education, dialysis type, and we're able to then abstract additional information like BMI, dialysis time, and measure other factors like frailty, impairments, and activities of daily living from participants. We also ask them to both self-report, and then we go through the medical records to ascertain all the comorbidities that are listed in the Charleston Comorbidity Index, which has been updated for patients with end-stage kidney disease. We also measure depressive symptoms using the Centers for Epidemiological Studies Depression Scale. It's a pretty easy 20-item questionnaire in which participants who have a score of 16 or more are indicated as having depressive symptoms. Next slide. The key variable that we were studying within this large cohort, in which there's a number of factors that are both directly measured, self-reported, and ascertained from clinical records, was sexual bother. These questions were all ascertained from the kidney disease quality of life short form, in which we were able to understand the patient's self-reported sexual bother, which is their negative impact of the sexual dysfunction due to their kidney disease. We have research assistants administer these questions, as I mentioned before, at the time of evaluation at admission for kidney transplantation. We also see participants post-transplant at all their clinical follow-up care at these two centers. And for that reason, we're able to get post-transplant measurements of the kidney disease quality of life short form, and by extension, the sexual bother measure as well. Next slide. So to dig in a little deeper here, there's a section in the kidney disease quality of life that asks about the effects of kidney disease on your daily life. It talks about fluid restrictions, dietary restrictions, ability to work, all the way down to sex life as well. Here, participants are asked to report whether kidney disease has an impact on your sex life as either not at all bothered, all the way through to extremely bothered. This is given a scores of 1 to 5. And we focused on this as sexual bother for the first part of our analysis. The second part, we'll be talking about sexual activity, and that was measured from a different question on the kidney disease quality of life short form, in which participants are asked, have you had any sexual activity in the past 4 weeks? No. Then you skip the next question. If yes, they ask, how much of a problem was each of the following in the past 4 weeks: enjoying sex or becoming sexually aroused? Again, we have from not a problem, a score of 1, all the way up to severe problem with a score of 5. So there is a branching logic there, but we have information on both overall effects of kidney disease on patients' sex life through to the number of to sexual activity in the past 4 weeks, and then the potential problems that they've had in the last 4 weeks. Next slide, please. To look at the sexual bother question, we estimated the odds ratio of sexual bother based on the different characteristics that participants either self-reported or we ascertained. We did this both for transplant candidates at evaluation as well as transplant recipients at admission. In the models, we included age, sex, race, partnership status, which was self-reported, smoking, education, the Charlson Comorbidity Index that I introduced earlier, whether or not they had depressive symptoms, and time on dialysis as well. Next slide. For the odds of, to look at the trajectories of sexual bother in the post-transplant period, we used a mixed effect logistic regression, which estimated the odds, which we then converted to percentages for ease of interpretation. And we looked at these unadjusted trajectories over the course of the first 3 years post-transplantation. With these types of models, you have to specify a reference population so that the percentages that are given are specific to a specific group, which we call our standard reference population. Here we set those to be age of greater than 60, non-Black male, partnered, prior or current smoker, less than a high school education, depressive symptoms, with a Charlson Comorbidity Index of 1 and time on dialysis of 2 years. This was the kind of most standard population that we could see in our cohort study. Next slide. We also looked at whether sexual bother trajectories differed by key factors that we a priori hypothesized may differ. And this was often rooted in the research that Jane so beautifully presented in the introduction today. We wanted to see whether the trajectories of sexual bother differed by both candidate and recipient's age, their sex, their race, their partnership, their smoking status, their depressive symptoms. To do this, we added an interaction between time of follow-up in each of these variates separately. So each variate had a separate model. And what we basically were asking here was, do the changes in sexual bother after transplantation differ by these key groups, older and younger, men and women, partnered and unpartnered, et cetera. So we were trying to find specific subgroups who maybe had more improvement or less improvement post-transplantation with this analysis. We also recognize that we're conducting a cohort study on a sensitive topic, and many participants may not feel as comfortable reporting this as others. To do this, we wanted to address the potential selection bias that could be introduced if you had missing or refused information on sexual health during this cohort study. We used a special causal inference technique called inverse probability of weighting to allow us to kind of reweight the population of observed to account for the people who we were unable to observe because they either had missing data or refused to answer these potentially sensitive questions. Next slide. And to go in a little deeper here, we did have 4.2% of the candidates and 3% of the recipients who were non-responders. If we look and see how they differed, we did see for the candidates that the older participants were less likely to respond to these questions, and those who had functional dependence or dependence in activities of daily living were again less likely to respond. Those two factors are highly related. So what we're seeing kind of overall is that the older and functionally impaired participants were less likely to report their sexual health among candidates. Among recipients, we found that never smokers, those who had preemptive KT and had shorter time on dialysis, were more likely to refuse these questions. But again, if we know this information about our cohort, we could do that previous inverse probability of treatment weighting to be able to account for differences in response. Thank you. Next slide. And back to you, Jane.
Okay, so now I'm going to go over the results. So looking at our transplant candidate characteristics, so this is everybody who was a candidate. The average age was 55.4, 38.4% were female, 46.6% were Black, 54.8% were partnered, and 54.2% never smoked. Median dialysis time was 0.6 years, and the comorbidity index had a median of 2. Candidates who reported sexual bother were more likely to be younger, male, partnered, prior or current smokers, frail, have longer time on dialysis, and have depressive symptoms compared to those who did not report sexual bother. And here we're looking at the prevalence of sexual bother at kidney transplant evaluation. So among male candidates, 49.9% reported no sexual bother, 14% somewhat bothered, 10% moderately bothered, 8.6% very much bothered, and 13.5% extremely bothered. And looking at female candidates, 66% reported no sexual bother, roughly 10% somewhat bothered, 6.5% moderately, 5% very much, and 8% extremely bothered. So younger transplant candidates had 1.5 times the odds of reporting sexual bother compared to older candidates. Male candidates had 2.13 times the odds of reporting sexual bother compared to female candidates. Those who are partnered, 1.93 times the odds compared to those who are non-partnered. Those who are prior or current smokers, 1.2 times the odds compared to those who are never smokers. Those who have depressive symptoms have 2.4 times the odds of reporting sexual bother compared to those without depressive symptoms. And those with a higher Charlson comorbidity index also had a higher odds of reporting sexual bother with a 4% increase per unit. 4% increase per unit increase. At evaluation, 39% of males and 34.5% of females were sexually active in the past 4 weeks. Among those sexually active, 28.9% of males and 30.4% of females reported problems enjoying sex, and 41% of males and 34.1% of females reported problems with sexual arousal. So switching gears, we're looking now at transplant recipient characteristics. So the mean age was 52.2, 36.5% were female, roughly 43% were Black, roughly 60% were partnered, and 57.6% were never smokers. Median dialysis time was 2.2 years, and the Charlson comorbidity index of 1, a median Charlson comorbidity index of 1. Transplant recipients who reported sexual bother were more likely to be older, male, non-Black, partnered, prior or current smokers, have a higher Charlson comorbidity index, have lower function of instrumental activities of daily living, and have depressive symptoms. So here we're looking at prevalence of sexual bother at transplant admission by overall and by participant characteristics. Among transplant recipients, 43.4% of male recipients reported no sexual bother, 18.8 somewhat bothered, 10% moderately, 12.5 very much, and 12.5 extremely bothered. Among female candidates, 69.7% reported no sexual bother, 11.9 somewhat, 3.2 moderately, 4.9 very much, and 7 extremely bothered. Transplant recipients who are male, partnered, previous or current smokers, have depressive symptoms, or have higher CCI were more likely to experience sexual bother or have a higher odds of experiencing sexual bother. At transplant admission, 41.6% of male and 41.8% of female transplant recipients were sexually active in the past 4 weeks. Among those who were sexually active, 29.4% of males and 11.4% of females reported problems enjoying sex. 39% of males and 21.4% of females reported problems with sexual arousal. And so here, among all transplant recipients who answered the sexual activity question, the observed prevalence of engagement in sexual activity increased and peaked at 1 year post-transplant for both male and female transplant recipients. And at 3 years post-transplant, 48.9% of male and 50% of female transplant recipients were sexually active. Prevalence at admission for sexual bother was 57.1%, which is 8 times higher, roughly 8 times higher than 3 years after transplantation. And there are no differences in sexual bother by age or race at transplantation. Sexual bother prevalence decreased in the first 3 years after transplantation, or roughly 61, the odds were decreased by 61% per year. These trajectories did not differ by age, sex, race, partnership, smoking, or depressive symptom. Our results remain robust after accounting for selection bias associated with missing sexual bother, and time on dialysis was not associated with annual change in prevalence of sexual bother after transplantation, and this association did not differ by sex.
Thanks. We can focus on some of the conclusions of this work next. So we found that sexual bother is common pre-transplant and improves after kidney transplantation. I think we've seen this type of result for other important patient-centered outcomes as well, like quality of life. But this digs down to kind of a specific domain of quality of life that we feel was important and that participants reported was important to their daily life as well. We also found that sexual activity increases after transplantation and peaks about 1 year after kidney transplantation. Sexual activity improvement has been sustained for 3 years of follow-up in our study. And finally, sexual health is an important aspect of a patient's lives and should be addressed during the pre-transplant management and discussed as part of transplant counseling. Next slide. There are some limitations to our work. We did explore a long-term sustainability of post-transplant sexual health improvements. That should be a focus of future studies. We did not incorporate any data on the impact of medications or therapies that are specific to sexual dysfunction, but there's literature on the importance of transplantation the importance of transplantation on the reducing the impact of medications and therapies needed for sexual dysfunction already. We also obtained very granular data on sexual function domains that are impacted by kidney disease, which is not part of our current study, but that could easily be done, particularly through qualitative research as well. We don't know, but are seeking to identify the best practices to train providers on sexual health counseling. I recognize that transplant providers have so many things on their plate to discuss with participants, but we do feel that this is an important aspect of health that is often overlooked and not discussed as part of the transplant process. We also were not able to evaluate whether patients were interested in sexual dysfunction education. This may be a piece that's important to them, but the timing and the delivery of this education is important and needs to be further underscored. We also recognize that the patient voice is very important. There have been some smaller studies that have looked at this, primarily among male recipients. And so we feel that understanding a diverse group of patients' perspectives and their partners' perspectives on sexual health pre and post transplant is an important direction for the field to move next. We do want to recognize that our research has many benefits. We've gone above and beyond a number of smaller studies that have primarily focused on single time points. They've been either limited in sample sizes, and we've been able to look not only at pre and post transplant, but to go as far as 3 years post transplantation to understand how sexual health changes after transplantation. And we've done this in a very diverse group of participants. You can see that our results, I think, are strengthened by the fact that we see that the improvements post-transplantation are not limited to a single group, but in fact are shared among many different types of patients that you may be seeing in your clinic as well. Next slide. With that, we'd like to thank the members of the Center for Surgical and Transplant Applied Research that's led by Dr. Dori Segev here, as well as the Epidemiology of Aging Studies, ESKD, the EASE lab, which I lead. They have been the ones that have been collecting and analyzing these data since we started many years ago. And we are excited to be able to continue to dive into this cohort study to look at novel research questions that are related to aging and beyond. Thank you. Next slide. With that, I thought we would start to take some questions now. We're happy to go back over any of the results or to dive in deeper in this discussion.
Thank you, Jane and Mara, for a great presentation. Really enjoyed this presentation. I am going to read the very first question. It is from Michael Hoffman. This was very interesting. Do you know how these rates of sexual bother compare to age comparable controls? Thanks.
That is a great question. That's unfortunately not part of our study design. My guess is the behavioral risk factors survey, the BRFSS, would be a good place to look to find that. I think we know that patients with end-stage kidney disease have unique challenges related to health and health-related quality of life. But we did not compare specifically to controls in this study.
Thanks, Mara and Jane. That was an excellent presentation and a great study. So I think one of the questions I had was, do you know how many were preemptive transplants in your cohort, or everybody was on dialysis?
There were preemptive transplants. Do you, Jane? Do you
have it? Let me take a look, and I will get back to you in a second.
as well?
Because I did see the median dialysis time was not that long. It was just 0.6 months. So was there any sort of like selection criteria which you all use? Because 0.6 is pretty less duration of dialysis.
So yeah, that's reflective of both the two centers that we conducted the study at. We definitely included preemptive transplant recipients, but the cohort study, since it's been started, has only had the criteria of 18 years and older, English speaking. We have obviously the center has moved from Johns Hopkins to NYU as of 3 years ago. And one of our big initiatives in moving to NYU is to expand the cohort entrance to also include Spanish-speaking patients as well. So the only two criteria were age and language. And with that, we will be expanding the language moving forward.
So like, did you notice any difference in, yeah, Jane, do you have information on how many were preemptive?
So for the transplant candidates, 33%, roughly 33% were preemptive.
So did you notice any difference in the sexual bother between preemptive candidates and candidates who were on dialysis?
Do you want to pull up table 1, Jane?
I am here. Let me pull this up. Trying to. Oh, sorry. So this is the table 1. This is for preemptive. So 28% of those who received preemptive transplant reported sexual bother, and 35.9% did not.
Which was lower than what we see for both hemo or for peritoneal dialysis. So I think, Silvi, I'm happy to hear you weigh in, but I think that's what we would have expected.
Yeah, because that's what I was thinking. Like and do you like have any specific reason why kidney transplant, why the sexual dysfunction improved at 1 and 3 years? Like, I think there's a question from one of the audiences was the similar question. What is by Dr. Angelica Amarande? What is the explanation of improving level of sexual activity at 1 year post-kidney?
I'm going to speak from the gerontology perspective here. We have done a number of studies looking at trajectories of frailty, of cognitive function, of functional status. And what we see is that there is this kind of always an initial decline in those kind of first 3 months as patients are recovering from surgery. But we see this robust improvement in frailty, physical function, cognitive function, health-related quality of life that happen very early in that post-transplant period. So I think that what we're seeing here is a restoration of vitality, of health, and that likely is leading to increased sexual activity. That is not something we explicitly studied. So I guess you could say trust an epidemiologist on that one. That's about just the summary of the gerontologic work that we've done so far in this population.
Yeah, and just hypothesizing the multifaceted aspects of sexual health and sexual function. Just there's so many different things physiologically that could be contributing, also psychologically, or some of that emotional or psychosocial component of that. After transplantation, no longer being dependent on dialysis, a lot of different components of life as well.
The exhaustion piece, I think what we see in that frailty phenotype, again, is such a driver of health-related quality of life. And I do just want to make a plug. I think some of the studies that have been previously done in this area have not necessarily relied on participant self-report. And as this important patient-centered metric, we think that it's really one of the benefits of the work that we did here was that we had the chance to allow patients to kind of express these changes in this patient-centered outcome as well.
Mara and Jane, how has this research of yours translated into clinical practice, right? When I think about my clinic, do I really address this on an, everyday basis when I see patients? Answer is no. So I would be curious to, understand how you have, adopted this into your clinical practice, and what tips do you have for, a lot of providers here who have joined this session? How can we address, this in our day-to-day practice?
Do you want to answer first? Or
Sure.
I will just say I don't have a clinical practice. I'm an
Yes.
epidemiologist. So, and Jane is a trainee. So
Yeah.
Yeah.
which I'd love to hear from you and Silvi. To me, there are so many fears that go into making that decision about transplantation and so many unknowns. I think we have very solid evidence here that this is a benefit of transplantation. We often say, at least in our research, transplant provides improvements in survival and in quality of life. Here we're getting into the facets of quality of life. That's an abstract concept. It's hard for patients to be able to say, my quality of life will improve. How can we actually map that to actual lived experience. And I think this type of research will help to do that. So if a patient says, what do you mean my health-related quality of life will improve? This gives some context to that. So that would be, again, my non-clinical perspective. Jane, did you want to weigh in before we turn it to Silvi?
Yeah, I think in an ideal world, it would just at least start with getting comfortable having those kinds of conversations and having more open-ended conversations, like, you know, about your quality of life and thinking about your health holistically, even though we usually focus on more, I don't know, other types of metrics, but just even asking about sexual health. Is this something you're even worried about? Is this something of concern? And then maybe as a provider, knowing where to refer patients, you know, being more maybe being more aware or plugged in into your institution about who provides sexual therapy or who can sort of redirect patients if that is of a concern and you may not have that expertise, just to keep those conversations going. I think that's kind of like a good starting point. And then also maybe using these conversations as a way to understand their fears or concerns about transplantation, or even as a way to motivate or encourage patients to come to follow up, or just keeping that open dialogue because, you know, you're caring about all aspects of their health.
Silvi, did you have any thoughts?
No, that's absolutely right. And I think the key takeaway, what I take away from the study is just awareness and, you know, talking this to the patients. Because I feel like as physicians, when we are seeing them, we really don't talk. We don't talk about sexual bother at the time of evaluation. We don't even talk about it at the time of kidney transplant admission or, you know, even during regular clinic visits. And I think just talking to patients about it, that it will likely get better, I think is a good starting point. And I also feel like it's very important. I think women may be more hesitant to talk about it as compared to men. Also, it depends upon if it's a male physician or a female physician. So I think there are a lot of other cultural factors as well, which could be related to it. So I think we have to keep that in mind. You know, like what mm, when we are seeing patients, like if it's a woman, if it's a male, and if they have any other barriers, but definitely address it. I think that's my starting point. Also, I've seen like patients may be sometimes very confused that they may not even know whom to ask this question, because when we are seeing these patients, especially in the first year post transplant, we are like their primary care doctors. So we take care of everything. They hardly go to their primary care doctor, especially in the first, you know, 1 year, first year. So I think we all need to be cognizant that it's important for us to tell them that things are going to get better. And I think just awareness and counseling is the starting point from here. Yeah.
Thank you. I appreciate hearing that clinical perspective. We don't always get that, but you know, we recognize that this is an important area for patients. And again, as we move towards more patient-centered holistic care, as you were all saying, this seems like this is a kind of a natural fit for expanding the discussion of the benefits of transplantation.
Right. So what are the next steps? Like, are you planning any other future studies based on the results of this study?
That's a great question. I'm quite interested in how, in the intersection of kind of quality of life overall, impacts with age, right? I think there's the guidelines on kind of the upper age limits for transplantation are not specifically set. And if we can understand which patients get the most benefit, particularly surrounding quality of life, as pertains to their physical health, their cognitive health, in this case, it was sexual health. I think that to me has been an important focus of my research and more work that we're planning to do here as well. I think the other kind of follow-up piece to this is to think about what we can do prior to transplantation to get patients primed and ready for a transplant. So what types of physical prehabilitation interventions can be done so that these benefits that we're seeing after transplant can be experienced even earlier on, right? Why would we have to wait till kind of, 1 year post-transplantation, as one of the members of today's journal club asked? Well, maybe we can move those benefits earlier into the transplant by reducing the amount of post-transplant recovery that we have. So prehabilitation, I think, is a big focus of our lab's work as well. We imagine that will have not just immediate perioperative improvements, but also other longer term consequences as well, right? The ultimate goal here is that patients get to receive a transplant and the benefits of a transplant as early as possible. And this may be one way to do that. Sorry, that was a bit long-winded. Jane, any thoughts from your end?
No, I think you summed up it really nicely, and getting longer term data as we continue to gather information from this FAIR cohort would be interesting to do some follow-up later on to see if these sustained effects go beyond 3 years.
Are there other aspects that you feel that we could have that we could look at with this type of database? I think naturally for us, a lot of the questions move more towards qualitative studies. So either structured interviews or focus groups to really understand what that person's experience is like and how that can be translated into research, I think is important. But do you see anything kind of through perspective of longitudinal cohorts that would be helpful to answer?
I think also like the mechanistic, like why this is happening. So that is why I was interested in, that question, like preemptive and duration of dialysis, because we know like with progression of kidney disease, there's more sexual dysfunction or more impaired fertility. But that's mostly, and with kidney transplant, everything comes back. But I think we really don't know why things come back. Like we don't know the real reason, like what are the real hormonal changes which occurs. So I think that would be very interesting to see that. And as we are seeing, like 3 years was better than 1 year. So, it just tells us that the time does make a difference. So I think that would be very interesting to see what is really happening, which is contributing to better return of, less of sexual bother and better sexual function after a kidney transplant.
Yeah, I think the other kind of a piece to add to that too as well. It's so complicated. Sexual health is such a complicated outcome to study, right? There are so many different factors that go into it that, there could be a number of both kind of biological, psychosocial analyses that would happen to really fully understand, kind of quantify this. I think there are probably patients who experience less of the benefit than others. We didn't see that there were any groups that were specifically disadvantaged. So I think trying to understand which patients could be referred to receive other sexual health care or urology afterwards may be a nice way to identify patients who aren't necessarily going to get the full benefit of transplantation that other groups are.
Yeah, and I think the other interesting thing which I noticed was that males had higher sexual bother as compared to females, right? So why do you think that was the case?
Yeah, these are kind of complex questions that I think would be best addressed with a qualitative study. It may be a difference in expectations, right? I don't think we have the breakdown of partnership by sex, but it could be that more of the males that were undergoing transplantation were partnered. That could be one of the drivers of it as well. But, it may also be due to measurement error, right? As we said before, women may be less likely to want to discuss this. It also depends on who's in the room with the research participant, whether they're willing to answer these questions or not. So I think there's the kind of underlying construct of sexual health and sexual bother. Then there's that layer of what we're able to capture through our cohort study. And it may be a complex mixture of both.
No, that's right. So we would encourage participants if they had any more questions. Right. Yeah, so any final comments from our speakers? Jane and Mara, any final comments?
I will make one. I think after reviewing the literature, it was so nice to be able to contribute a study that was both diverse in the age, the sex and genders that we were able to study, time frame, race, ethnicity. I think we would want to encourage that any next steps forward look at the kind of largest possible swath of the transplant population to better understand sexual health. Too many studies had been limited, I think, in the past, and we're just very happy that we're able to contribute this because we see that the improvements are really among all different groups that we studied here. So that would be kind of my encouragement to the field moving forward. Jane.
I agree. I think it's good to keep this conversation going. I think sometimes it's easy to say, oh, we kind of know about this and this is what's available. But yeah, there's still so much to learn, so much to explore and understand. And yeah, thank you for the opportunity to present our work.
Thank you, Jane and Mara, for a great journal club. Really enjoyed it. Thank you to the Women's Health COP and Kidney Pancreas COP for sponsoring this journal club. And thank you to Brian and Olivia for hosting this session for us. Incredibly, thank you to have you here. Thank you.
Thank you so much. AST would like to thank Drs. Long, McAdams-DeMarco, Vasanth, and Shah, the AST WHCOP and KPCOP, AJT, and all of our attendees for today's session. Please remember to complete the evaluation survey in Zoom and visit myast.org/education to view our video archives and register for upcoming journal clubs. Thank you all for today's session.